coming, and thank you for the kind invitation. It's a pleasure to be with you here. And if you can put the slides here. Yes or no? Good. So let's speak about FP1s, how to get predictable result in this new digital era. And I want to tell you the story of my practice. How did I start doing this with many years ago with the analog tools we have at the moment, and what we do right now with the digital tools we have right at the moment. And it's a different world. Nowadays we are more efficient. Everything becomes easier thanks to not only the intraoral scanner, but also some devices like, for example, photogrammetry, the PIC system. You were watching before the promotion of the PIC system. And this lecture is about that, about how to get predictable results when I have to rehabilitate the full mouth with implants. First of all, allow me to introduce myself in a more human way. I trained here in Santiago de Compostela. This is the cathedral, and I live in a small town called Ponferrada. I travel a lot all around the globe, so I travel a lot to Madrid to take the flights from time to time. You know, and this is my city, surrounded by vineyards. This is the castle in the middle of the city, and there I have many groups from all around the globe as well. And this is what I like most, the countryside. And you can see the valley from a mountain. When I have time, I spend time in the mountains to disconnect from the dental work, because dentistry is quite exhausting, you know. It's very stressful, and you cannot be the whole day thinking about teeth, because it's not healthy, okay? So this is my hometown, and this is where I practice and where I enjoy to spend time with friends. And in another city next to the sea, La Coruña, I have another training center. This is a beautiful place as well, in front of the sea. And as you can see, I really like the green, you know, the countryside once again. That's what I do. During the last decade, dentistry has fully changed. And now we do this. Everything is done with a digital workflow. And for a single unit, it's quite easy, because we have the right precision with the intraoral scanner. But for a full arch, it's not so easy. And this is the workflow we follow for a single unit. We take the digital impression, we plan everything virtually beforehand, and then we jump to the surgery. And during the surgery, the implants, I think the image is stretched. I think the image is stretched. Yes? Sorry. You know what I mean? The image is, yeah, it has to be stretched. Anyway, we manufacture the surgical templates in-house. Nowadays it's really cheap, and it can be done efficiently. And we put the implant, we register the position of the implant with the scan body. We don't reconstruct the hard and soft tissues. I mean, the socket preservation is done at the same time the implant is placed. Sometimes bone, sometimes bone and soft tissues. It depends on the anatomical condition of the socket. This is important because when we jump from here, from one single unit to the full arch, we have to do the same. We have different sockets with different conditions, and we have to reconstruct properly everything. Thank you so much for this. And then we manufacture the provisional at the office in-house immediately. And this is a PMMA, monolithic multi-layer provisional. You don't have to reline the provisional anymore. Now the milling machine or the printer is working for us, and we are saving tons of time. And in the meantime, we can see the patient, we can do another thing. So we work much less. Everything becomes easier. We are not better dentists because we have intraoral scanner, but we are able to work much less, more efficiently, and we are less stressed out. And finally, after a couple of months, we substitute the provisional for the final restoration. And if you don't layer ceramic, you don't need a model. In most of our cases, you don't need to layer ceramic over the zirconia framework, because most of our cases are molars or teeth with a easy color to emulate. So the workflow is quite straightforward. And we can do this, and we can repeat the procedure hundreds of times, and every time it becomes easier, every time we become more efficient doing this. But if we jump to the full arch, things are sometimes a little bit more complex, because now we have to place more implants. Every socket has a different condition, and every situation is absolutely different. And I want to make clear that I do everything, not only FP1 rehabilitations. And some patients need overdentures, other patients need hybrid dentures, other patients maybe scallop dentures, FP1 rehabilitation. I have patients with defects, I have patients with periodontal disease, upper jaw, lower jaw, so every situation is absolutely different. So we cannot compare that case with this one, because even when I can put sometimes 4 or 6 implants, maybe I need an overdenture to support it, because I have to rehabilitate the face of the patient. The same with the vertical dimension. Maybe I have the defect is too severe, the bone defect is too severe, again, I need a hybrid denture, I need a pink gingiva. But in many cases nowadays, we are able to end up with natural looking results. And not only in those cases where I have a good quantity of bone and soft tissues, but thanks to microgingival therapy and thanks to bone augmentation techniques, we are able to change the predictability of cases where I have moderate defects. And this is what we changed throughout the years. We changed the protocol. But before I want to introduce you, before speaking about FP1, other solutions. For example, look at this case. In this case, or this other case. You know, in these cases, I have to evaluate 3 main determinants. The face of the patient, the vertical dimension, and the anatomical condition. If the bone defect is too big, I need a hybrid denture. If I need to support the lip of the patient, I will need maybe an overdenture. And modifying the vertical dimension allows me to select one prosthesis or another. So depending on these 3 determinants, I will establish my treatment plan. So diagnosis is paramount, and I need a strategic treatment plan before going for the treatment. For example, look at this. And this was done many years ago. That's the reason you see a Walks ring. And we tried out a denture before rehabilitating the patient, and we realized that we needed to support the lip of the patient. Of course, we have to leave a freeway space around 2-3 millimeters at least. And This was the condition of the patient before starting the treatment, the rehabilitation. I pulled out all the teeth, and with the analog workflow, I put several implants. We analyzed the vertical dimension of the patient. We established the position of the incisal edge. The incisal edge of the central incisor is the most important point at the time of the diagnosis. And then this is the trying, denture trying, and this is the final rehabilitation. As you can see, I selected an overdenture because I need the flange to support the lip of the patient, and I have too much defect there. The anatomical condition of the patient is poor, even when you could use a hybrid denture because you have enough implants. The best treatment is an overdenture, not a hybrid denture or a fixed denture. It's a removable denture because I need to restore the face of the patient. And this is the final result, from baseline to the final rehabilitation. So the ideal treatment for this patient then was an overdenture, not a fixed denture, because vertical dimension had to be reestablished. And we needed, with the flange of the denture, to support the lips of the patient. Another patient coming to my office with this condition, I didn't place the implants. You see there several Straumann implants, but the patient was not happy with the removal of denture, with the provisional, and they said to the patient he needed a resin metal denture. He didn't agree with the treatment, so he switched the dentist. And here, once again, I need to support the lip of the patient, but vertical dimension is not so high. So I selected a hybrid denture. This is a fixed denture. PFN in the upper jaw and composite fused to metal in the lower jaw because the patient was a braces. Here I can rehabilitate the patient with a fixed denture, at the same time to support the lip of the patient, to reestablish the position of the incisal, of the central incisor, and to end up with a balanced result, combining PFM with composite because the patient is a braces. And in order to be sure that the incisal position, the incisal edge of the central incisor is in the right position, in the analog era, I had to do these tryings, okay? I needed to check out that everything was right. Nowadays, you will see everything becomes easier with digital workflow. I don't need to work so much. But it's important, no matter you use analog or digital workflows, that you check out that the central incisor is in the right position, okay? And of course, the occlusal plane before jumping to the final rehabilitation. And this is before and after, okay? If diagnosis and treatment plan is executed in the right way, the treatment is not difficult, okay? Another patient, you can see, with too much vertical dimension, so I need pink gingiva. And this is zirconia, ceramic fused to zirconia. And why I do need the pink gingiva? Because I have vertical defects and the patient is very old. She's not interested in complex bone augmentation techniques. So the best treatment option here is a hybrid denture, not a natural looking rehabilitation. I don't want to complicate the life of the patient because you can see that they have a vertical defect on the right side of the mouth. So it's much easier to simplify the treatment. I'm showing you these treatment options in order you to understand that every single case is different, because later on I will speak about natural looking results, but not in every patient I can employ the same workflow. But now with the digital era, everything becomes easier. I put the implants, I scan the implants. Scanning the implants is not enough because we don't have enough precision. I will repeat this several times. I don't have enough precision with an intraoral scanner to register digitally the full mouth. An intraoral scanner is precise enough for 1 piece, 3 pieces, maybe 4 pieces, but not for the full arch. So I have to combine this registering with the PIC one. The PIC one is a photogrammetric engineering device, which registers the position and angulation of the implants with a 25 microns precision, accuracy. 25 is a lot, much better than silicone impression, okay? And then we finalize, and you can see the treatment, and you can see the lady has a low lip line. She's very old, and she has a low lip line. There is not any meaning. It's not very clever to do a vertical bone regeneration, even when I like vertical bone augmentation, to spend so much time with the treatment in this old lady who is not showing the transition area is maybe a waste of time and energy. So you see that the incisal edge position is right, the result is pleasant, no reason to regenerate those defects, okay? Another patient, and look at the profile of the patient before and after. I need to increase the vertical dimension in this patient to rotate the mandible. In that way, maybe I'm able to change the occlusion. And this is what I did. And we went from here to there. And this result is not a hybrid denture, it is a FP2 denture. Longer teeth. Longer teeth or pink gingiva depends on your preferences and the preferences of the patient. But the result can be pleasant as well because this patient doesn't show, once again, doesn't show the transition area. So this is a solution for this patient. Of course, you can say to me, hey Ramon, you could use here a hybrid denture, and you're right. Sometimes there is more than one single possibility. You can use more than one single, there are several options. Another patient, once again, with done with digital technology, we register the position of the implants with the intraoral scanner, with the PIC system. And another device we use lately is the Sebris, a digital face bow. With the digital face bow, we are able to put in the right 3D position the upper jaw into the software. So we are very precise in the position of the maxilla, in the 3D position of the maxilla. And this is very useful in order to wax up the full arch, to position in the right way the incisal edge of the central incisor. And from there, I end up establishing the position of every single tooth inside the mouth. And it was, it's very easy to use. There are several sensors connecting, the device about the sensors connecting about them, Sorry. Let's see the video, how it works, for you to understand. So we put a little bit of silicone there to register the teeth of the maxilla, and the digital face bow is put on the head of the patient, and with this sensor we detect the relationship between the cranium and the maxilla, the upper jaw. that is put inside the software, and the face valve can be used in order to manufacture a night guard, or in order to wax up the full arch, whatever you need. But we know for sure that the position of the maxilla, the 3D position of the maxilla related to the head of the patient is very precise. So this is changing the game, because now I have everything inside the computer. I don't have to work with articulators, I don't have to work with plaster, everything becomes more straightforward. And then I can plan, I can design the final rehabilitation in the right way, and this is the result. This is baseline, and this is the rehabilitation after placing several implants, everything done with the digital workflow. You can see that playing with the vertical dimension, planning everything properly allows us to select different kind of treatments depending on the patient and where the position of the transition area is located. So this is what I wanted to tell you before starting with the FP1 rehabilitation lecture, that every patient is completely different. And now let's speak about FP1 after the introduction. There are many patients with edentullism in the world, every year more and more, because the population of the world is bigger. So to know how to treat the patient with edentullism is very important for the dentist. And look, 20% of the global population, 65 or older, suffer edentullism. It's a lot. It's a lot. And 35 million of Americans only in America are dentals. A lot of people, once again. And the problem with dentures is that they don't comply with the psychological needs of the patient. Okay, the patients, after putting a removable denture, half the patients are dissatisfied with the result. And you end up checking up the patient between 5 or 10 times after putting a removable denture. It's a lot. Everybody here knows that this is happening. The removable denture nowadays is not the solution for the patient. Even for very old patients, the quality of life after putting a removable denture is being very low. And on the other hand, we know that immediate loading is predictable, not only in the lower jaw, but also in the upper jaw. There is strong evidence about this. Many papers talking about it. And there are many ways to go. After extracting the teeth, I can put the implants immediately. I can wait several weeks for the soft tissues to heal, or I can wait several months. But once again, before entering the FP1 lecture, I want to say that I want to sign out how important is to provisionalize the case immediately in order to facilitate the loading in complex cases and the healing of the ridge. When we are going to rehabilitate complex cases, it's very important to deliver a provisional as soon as possible to avoid compromising the quality of life of the patient. Because if I remove all the implants or the failing implants, for example in this case, and I put a removable denture, the quality of life of my patient drops down. And not only that, the removable denture damage the little bone I have here, and I end up with anything, without anything. Look at those cases I'm treating right now, all of them complex cases, where the patient comes with periimplantitis, he needs zygoma implants, and look at the vertical defect we have here. if I don't put some implants there to support a provisional, it's very complex to regenerate this vertical defect. But putting here a provisional, some implants loaded with a provisional, allows me to regenerate vertically this defect later on with a better predictability. So immediacy in my office, in my clinic, is used many times to avoid compromising the quality of life of the patient and to avoid losing even more bone. Because if I extract all these teeth and I put removable denture, I'm losing a lot of bone. This is the first clinical case. And the patient is coming with failing implants. Look at this implant in the lower jaw. All the threads exposed. You see? Very bad condition. I remove the prosthesis, but I don't want to remove all the implants. Because if I remove all the implants, to reconstruct the bone horizontally and vertically is gonna be tough. Tougher than preserving some implants and using those implants as a way to hold the denture for some months before having enough quantity of bone. So with some implants left, 3, 4 implants, I was able to keep the prosthesis, and then I regenerated the bone horizontally and vertically. You can see that with a titanium mesh and some mixing autogenous bone with allograft, I was able to regenerate the bone horizontally and vertically. Those implants I left there with the prosthesis allow me to keep the quality of life of the patient, okay, without compromising it. And look at the result after several months. This was before and this was after. Then I will place more implants, new implants. I planned everything virtually. I planned to put several implants there. But thanks to keeping some implants and the provisional, I was able to regenerate the bone more easily. Without implants, without removable denture, I couldn't be able to get so much bone. Now with a surgical guide, easily manufactured at the office, I put my new implants there. I regenerated the bone around the new implant in the lower jaw as well. And then I jumped to the digital workflow. With my just recently placed implants and some multi-units screwed onto the implants, I register the 3D position of the implants and I take a photogrammetric impression. And with that, I'm able to manufacture a new provisional, to mill a PMMA provisional. And it's really easy to keep the vertical dimension of the patient because we overlap, we match the previous file with the new ones. I reconstruct the soft tissues. I took a free gingivograph from the palate because I need to reposition the vestibule and to increase the band of keratinized tissue and the width of the gingiva. But everything is easier because I have a provisional. I have a fixed prosthesis during the procedure. You can see there, everything was done at the same time, the implant placement, I screwed the multi-units, I did the free gingivograph, everything in one single surgery. Of course, there was a previous surgery, remember the bone augmentation surgery. But in every moment, the patient went out of the clinic with the original prosthesis or the PMMA provisional. And this PMMA provisional is a copy of the previous prosthesis. And the cost of the provisional meal at the office is 20 times less than the cost of the provisional done at the laboratory. 20 times less. Now we wait several months for the osseointegration, and you can see that they removed, in the end, every single implant. But look at the condition of the bone. The condition of the bone is quite good right now. Impossible to reach that level of bone if I substitute, if I remove all the implants and I put a removable denture. And that's the reason I speak about strategic treatment plans. You need a strategy, okay? You need to think about how to treat the patient step by step, because every treatment is different. Not only to think about the treatment plan, but your strategy in order to tackle this clinical case. And this is the final restoration, and this is only something we did in the past to check out that the peak work nicely, properly. We don't do anything anymore because the peak system works nicely. You don't need to do that. But at the beginning, we checked that the precision of the system was right. Okay, and you can do that with a zirconia framework. If you have passivity, it doesn't work. If you hadn't, it would work. It would break, sorry. Okay? If it is passive, it doesn't break. If it is not passive, then it breaks when you screw that framework onto the multi-units. And this is the final rehabilitation. And this is the final prosthesis. Okay, easier to do step by step. Look at this other second case. Patient comes with no bone at all, no bone peaks. Then I need to give the patient back a quality of life, because the patient cannot bite anymore with a removable denture and that condition. And in order to do that, I placed several implants and a couple of zygoma implants. But the zygoma implant is not enough to place zygoma implants. I have to reconstruct the bone and the soft tissues all around the zygoma implants to guarantee the long run the stability of the result. Because without bone, maybe we end up with the oral-antral communication in the long term, not soon, but in the long run. There are right now many complications around zygoma implants because people are not reconstructing the bone around the head of the implant. And this is mandatory. And also to reconstruct the soft tissue condition. And people asked me yesterday, because we were lecturing for 2 days about immediate implant placement. Do you remember when we were chatting about this? How do you match the files into the software when you open up big flaps and you lose the references? And this is a way to go. Before raising a flap, I screwed this kind of PMMA plate there onto the palate. I scanned the maxilla before doing anything. And then when I open up my flaps, you know, and I'm losing the references, but I kept this one. And this one allows me to match the files into Exocad. You get it? And that's the reason it's not flat. It has some indentations. It's like a Lego piece, you know? It's screwed there. So the computer recognizes very easily. And the matching is perfect. Later on, I will present another case in the lower jaw, and I will show you how to do it in the lower jaw, where we don't have any palate. But if you have the palate, you can do that. And then, after placing the implants, reconstructing everything, this is the peak, once again, the peak flags. I register the precision of the implants precisely, and I printed the denture in 1 hour. So the patient went out of the clinic with a denture, not only the implants, and the hard and soft tissue reconstruction. And this is much better for me, not only for the patient, for me also. Why? Because now the patient is biting with a fixed prosthesis, and I don't have any removable denture. So the possibility of a complication, because a removable denture is applying pressure onto the bone augmentation, is very low. I don't have that possibility. I don't want to put there a removable denture. You get it? Immediate loading is not only to give back the patient aesthetics. Immediate loading allows me to get more predictable results, to increase the predictability of my bone augmentation techniques. Because if I have a fixed prosthesis, now everything is gonna heal better. And the patient was having breakfast with some dentists who work with me that week over my shoulder. I have dentists with me almost every week at my office. And they were having breakfast together, and the patient was perfectly, without any pain, almost no swelling, and he was happy. For the first time in many years, he had once again fixed teeth, and he could bite without any problem, okay? And this is finally the final hybrid denture with this is a zirconia denture cemented onto a titanium bar. Everything is screwed onto the multi-unit abutments. Good. Third case, look at this clinical case. And the patient, another failure. This was the third case I presented previously. I introduced you 3 radiographs. Patients coming to me with this condition, failing implants, and this huge vertical defect on the right side of the mouth. What do I do here? If I reconstruct the bone after extracting the teeth and I put there a removable denture, I will lose the little bone I have here, and the bone regeneration will fail for sure. So the last thing I want to do here is to put a removable denture. I need a fixed denture. So immediate loading was done here with that purpose. I put some implants, I register once again digitally the position of the implants with photogrammetry as well, and after placing those implants and a fixed provisional, I went for the vertical regeneration. And after several months, I exposed the implants, and now, once again, you have to repeat the digital impression. And I want to stop here. Because people say to me that in Spain, say to me, Ramon, these devices are too expensive. And I say, no, they are costly but not expensive. Because if you want to register with silicone, you need to take so many impressions with silicone. You need trays, you need implant replicas, you need temporary abutments, and so on. You have to understand, in these cases, so complex, you need several impressions. And the time you are saving using digital workflow is worthy the investment in these devices. Because it's not possible to jump from there to here with one single impression or one single provisional. We cannot do that. This is the vertical regeneration, 10mm vertical regeneration, and it was successful because I had a fixed prosthesis in the anterior part of the mouth and on the opposite side, and the patient could bite without applying pressure onto this area. This is the evolution relining. And wow, the provisionals, look at the condition of the vestibule before and after the vertical reconstruction. There was not any vestibule left, of course, because previous failures. Implant failures with periimplantitis drove the patient to that condition. Now, thanks to vertical regeneration, I reestablished a balance, and this is the condition of the maxilla before delivering the final restoration. But I needed a second provisional. And you see the vertical defect with the first provisional, then the trying, and the final rehabilitation. And this is FP1. Even with that condition, I was able to deliver a FP1 zirconia prosthesis cemented onto a titanium dirt. But it took me 3 years and several provisionals and several impressions, digital impressions. You have to understand that this is very complex to do without the digital workflow. Because every impression, digital impression, takes only 3 minutes, 4 minutes. But if you want to do it in with analog tools, with silicone, it takes sometimes half an hour, 1 hour. You have to cut off to check out the passivity, etc. You know how it works. And we went from here to there, 3 years later, but the patient was very happy, and me too. So coming back to the lecture, so why do we place implants immediately and we load them? Because we reduce treatment time, we reduce morbidity, but also we facilitate the treatment plan. We guide the soft tissue healing, and the patient is gonna be happier, and the patient is gonna accept the treatment much easier because we don't compromise his quality of life. So it's not only about treatment time, efficiency, and reducing morbidity. It's about getting better results, guiding the bone augmentation and the soft tissue healing. The drawback of this is, there is always a drawback. We need knowledge. We have to be trained in implant dentistry. We have to know our system, the connection, the surface. We have to know how to plan, how to use softwares, how to plan the implant position virtually beforehand, before the surgery. And we need to master bone augmentation techniques and soft tissue management techniques. Mainly soft tissue management, because soft tissue management is mandatory in almost every single case. It's very difficult that you find out a case where you have tons of hard and soft tissues. In almost every single case, there are defects you have to reconstruct. So basically, we are going to speak about this, the combination of different fields. The traditional facial-driven diagnosis. And this has not changed throughout the time, throughout the decades. Everything starts with the incisal edge position, the central incisor position. So we have to look at the face of the patient to analyze the vertical dimension. How much bone do we have? Because if the defect is huge, we need a hybrid denture or maybe an overdenture. And then we place the implants immediately, and if possible, we load them depending on the primary stability. And we boost the soft tissues if the phenotype is thin. And lately, thanks to new materials and new technologies, we can speed up the procedure and everything becomes easier. And this is exciting mainly for young practitioners who are going to practice, who still have 30 years or 40 years of practice. They have to learn how to practice more efficiently. It's not about working harder, it's about working smarter, okay? And we have to understand that my purpose is to get a natural looking rehabilitation. I have to understand that I need to manage the emergence profile of the implant-supported rehabilitation, implant-supported crown, but also the pontic sites. I need a natural-looking emergence profile at the pontic site also, not only the implant-supported crowns. Everything has to be combined. And there are, we published a paper describing 3 areas in the emergence profile of an implant-supported crown. And the most important area for me is the crestal one, the green one. Those 2 millimeters, 1.5, 2 millimeters, have to be straight to avoid too much pressure onto the bone. If I apply too much pressure onto the bone will resolve and I will lose it. And I will not be able to recover the bone. So pay attention to this. Don't apply too much pressure onto the bone. The emergence profile should be smooth, straight, not very aggressive, not very wide. And then we establish the other area. The next area is the aesthetic one, but this is not the critical one. The critical one is the crestal area. That is the critical one from a biological point of view, because the aesthetic one determines only when where the gingival margin will be established. The gingival margin position depends on what is the design of this outline, the aesthetic area. But you can modify the aesthetic area 100 times without any damage onto the bone. Because basically what you are doing is to pushing the gingiva upward or to allow the gingiva to go down. Putting more composite or removing composite. But there is not any biological risk in modifying the aesthetic area. Okay, and finally you have a bounded area. Bounded area is the one connected, the crestal one and the aesthetic one. And this bounded area should end up, should be almost straight, but in the end, you should have a concavity. The provisional or the final restoration should be under contour. Because with that concavity, you allow space for the soft tissues. And in many of our cases, we will graft connective tissue to change the phenotype, to increase the thickness of gingiva, to make everything more stable and more predictable. Because we need predictability, we need the stability in the long run, not only for a few months, in the long run. And that stability is given by the thick gingiva. And sometimes we don't have it, so we have to graft it. Those 3 areas are different, absolutely different. But if I learn how to manage it, everything becomes easier. The first crestal one is made of connective tissue, and the other 2 epithelium, junctional epithelium and the epithelium of the sulcus, for a single unit, but also for a full arch. But if I have a full arch, the first area, the first zone is the crestal zone, is the multi-unit abutment. If you use multi-unit abutments, the multi-unit abutment design constitute the first area, the crestal one. And that's the reason we are going to use 2 millimeters or 2.5 millimeter high multi-unit abutment. Don't use very short multi-unit abutments. Use at least 2 millimeter or 2.5 high multi-unit abutment. Okay? This is important. So I will place the implant 4 millimeters away, the head of the implant, 4 millimeters below the gingival margin. And I will use a multi-unit abutment with 2 millimeter height, or 2.5, depending on the system. at least that, not 0.5. Because if you put a very short multi-unit abutment, the emergence profile is too aggressive. And sometimes you compromise the bone. You don't allow the biological width to be reestablished. You push, you apply too much pressure onto the tissues. So those details are important in order to keep the stability of the bone. And this is my goal. Look at the thickness of the gingiva. Look at the width of the multi-unit abutment and the thickness of the gingiva. If you end up with that thickness, that is stable. Don't be afraid of having a gingival recession in the long term, because it will not happen. Gingival recession happens when the mucosa is very thin, or you have a bone dehiscence. But if you have bone, the bone is stable and the soft tissue is thick, no way you will face gingival recession in the long run. This is absolutely stable. And by the way, I waited 1 year with my PMMA provisional before switching the provisional for the final restoration. 1 year means the situation is very stable before jumping to the final restoration. And I will explain later why do I need to wait 1 year, not 3 months or 6 months. 4 months, 3 months, 6 months is enough for a hybrid denture, an overdenture, but not for a FP1. If you want excellence, you have to pay the price. And the price is, you have to wait. You have to make sure that the condition is very stable before jumping to the final restoration. So for a single unit, we are using zirconia crowns cemented onto tie bases. And once again, I repeat, the tie base height should be 2.5 at least. And with the correct design, please don't select tie bases which are very, very wide. They have to be concave, straight. Okay, the design of the tie base has to be right. There are many good designs in the market right now. There were not so many in the past, but right now we can do that. And if the implant is in the right 3D position, I can finalize my treatment with a zirconia crown cemented onto the tie base. And this is cheaper, quicker, and easier than using a customized abutment. Of course, don't get me wrong, a customized abutment is perfect. It's a good solution, but very expensive. We don't need it anymore if the implant is in the right position. But I'm not telling you that a customized abutment is not a good solution, because I did use it many, many times. It's the ideal solution, but we know much more nowadays. We can make our life easier. And then for the full arch, this is single unit. In the full arch, the situation is different. I use a multi-unit abutment and then the prosthesis. Why I use a multi-unit abutment in a full arch? Because in a full arch, the situation, clinical situation, is absolutely different. Now I have many Pontic sites. I don't have any Pontic site here, but I have Pontic sites there. So I have to connect and disconnect the prosthesis many times. Why? Because I have to push the gingiva, to shape the gingiva at the Pontic sites, not only there. And I don't want to connect and disconnect many times the provisional from the head of the implant. I want this piece to be stable. I don't want to interfere the biological balance I achieved there. So I need a piece, a different piece, to be able to connect and disconnect the prosthesis without interfering with the connective tissue at the level of the crestal zone. Get it? Good? Good? Then, look at this. This is a patient with the periodontal disease, advanced periodontal disease. And we were told we cannot place implants here immediately, because we were told that this is unpredictable. If we place implants there, the result is unpredictable. Maybe I will face many complications. Yes, but knowledge is changing constantly. Okay, don't place the implants immediately there, so you extract the teeth and you put a removable denture. And my question is, after 3 months, 4 months, how much bone is left there? What are you going to do? To put zygoma implants? Because after 3 months, you don't have bone anymore. Actually, on the left side, I need a sinus lift procedure. So a removable denture doesn't seem a good solution for this case. On the other hand, look at the bone. Even underneath the nose, you have maybe 8 millimeters of bone left. If you put there a removable denture, you end up with 4. Everything will become a disaster. And on the other hand, you have this situation where, look at that, I don't have enough tissue, not enough keratinized mucosa. Of course, part of the bone is gone. So what do I do? Putting immediate implants there and a prosthesis is not enough. If I put there implants and a removal and a provisional, I agree with the papers. The result will be a disaster. You will face many aesthetic complications: gingival recession, collapse, horizontal and vertical collapse. Even if you fill the gap between the implant and the cortical bone plate with xenograph, you will have many problems. Only after a couple of years. In these cases, we were told that maybe we have 2 millimeter gingival recession in only 1-2 years. But I put the implants, the multi-unit abutments. I didn't load all the implants, of course. On the left side, I needed a sinus lift procedure, so I cannot load that implant, but I can load the other 5 implants, the rest of the implants. But you see the cervical guide in order to be precise enough. But I didn't place the implants. I didn't place the implants without anything. I did graft the sites also. I used connective tissue grafts all around the implants in the anterior area. And this is changing the game. Because now the gingiva is thicker, is becoming thicker. I will end up with a wider band of keratinized tissue, and I'm boosting the gingiva, I'm boosting the phenotype, I'm changing the anatomical condition of the patient. And look at the healing, only a few days later. Few days later, you can see, let's go backward, embrasures were left opened. And a few days later, the tissue, there is so much soft tissue because I grafted the site that the connective tissue is occupying the embrasures. Now I have a thick gingiva, not a thin one anymore. And after the maturation of the tissues, you can see that the band of keratinized mucosa is wider and the situation is more stable. You can go for the sinus lift procedure now. I raise the membrane, I put another implant here, I reposition the bone wall. This is very easy. 15 minutes and it's done. But now it's easier to do that in a more predictable way. Because I have a fixed prosthesis. No removable denture is going to interfere with the healing of the sinus procedure. Because I have a strategy. And now the implants are loaded, and that side is very stable. I removed the frenulum, and here it is, my provisional healing. It seems another case, but it's the same case. Of course, maybe I'm not God, and maybe I have to repeat some procedures, but this is taking 5 minutes. You take a CTG from the tuberosity, and I harvested those pontic sites because they are still narrow. You remember the defect I had here was huge. So now I put there inline grafts. It takes nothing, only a few minutes. Actually, it took me more time to take the pictures. And you put there the CTG, and it's impossible you lose a CTG like this because you have done a partial thickness incision. Blood supply is so high, I never seen a failure with these procedures. This is extremely predictable. You don't have to be skillful. Every GEM practitioner will have the same results as me. Okay? So you know that this is perfectly predictable. So I put 2 CTGs there, I reconstructed the pontic sites, I exposed my last implant, and now the condition once again has improved a little bit more. Look at the stability of the bone after several months, and now the transition area. Do you remember the transition area before? I had a huge defect, vertical defect on this side. I didn't go for a bone augmentation. I did everything with soft tissue. So everybody can do this in a predictable way. It's about having the strategic treatment plan, having an idea, looking at the patient differently, but it's not about using difficult techniques. And this is the final restoration. And I was told that this was not possible. Okay, you have the papers saying that this is not predictable. But papers are not written by God, are written by human beings. And knowledge is changing constantly. Constantly. In every field, not only in dentistry. Look at dentistry. 10 years ago, nobody had an intraoral scanner at the office. Nobody used photogrammetry. And many colleagues said that digital workflows didn't work 10 years ago. Now, half the dentists in Spain have an intraoral scanner. But the pioneers, the leaders, the key opinion leaders are different. 100% of them have intraoral scanners. Because you need to think out of the box if you want to advance. If you want to keep your body in a comfortable area, then you will practice in the same way some guys practiced 50 years ago, and this is not good for you. So you have to think out of the box. And it worked. And this is a case I did almost 10 years ago. It's not the recent case. You can see the provisional and the patient very happy. But I didn't do this because I wanted to get a nice aesthetic result. I loaded my implants because it was the best way to preserve the little bone I had. Because people think I'm worried about the aesthetic result. No. What I try to prevent is complex procedures, complex surgeries, driven by placing a removable denture there, which is compromising the little bone left in this patient. So I'm thinking about biology, function, and aesthetics, not only about getting an aesthetic result. I'm thinking about what is the best thing for my patient. And of course, I couldn't get this result only shaping the emergence profile of the implant-supported crown. I need how to manage the pontic sites as well. And there are many designs in the market. There are many designs published, and all of them work. We have to know when to use one or another. This is the conical design published in the 90s. It's a prosthodontic design. It tries to hold the gingiva, putting composite into the socket. It's okay, but the problem is that in the long term, that gingiva is so thin that sometimes this condition is not stable. So it's something that I don't really use nowadays. You can use it, but only if I have a very favorable situation, a very thick phenotype. Then you can go for it. But you have to have, you need a thick cortical plate, and you need a thick gingiva, something that most of the times we don't have. Hygienic pontic design can be used in all patients, for example, lower jaw, when I don't want to reconstruct vertically the bone. I don't want to reconstruct vertical the bone, neither reconstruct vertical the bone, nor to press the hyperdenture, to compress too much the tissue with the hyperdenture, because if not, the patient cannot maintain properly the hygiene of that prosthesis. So sometimes I get a compromised situation. Ridge lap and modified ridge lap are used every day at my office, but with the provisionals, not with the final restoration. With a provisional, I hope to have, if I have enough time, I will show you a case like this with ridge lap and modified ridge lap. With the provisional, I can analyze the length of the crowns. The provisional is used as a walk set. Then I will graft the ridges, and I will switch this design for another one. But for the provisional, it's useful. For the final restoration, it's not, because I have a concavity and the maintenance of it is almost impossible. And the crown appears too long. We published 2 new designs. I published 2 new designs some years ago. The flat and step pontic designs, but for periodontally reconstructive sites. Why did I do this? Because I've been using this for 15 years. It's nothing new, but they published recently, a few years ago. Look at this. Most of us, myself, I use a lot the ovate pontic. And this is right, ovate pontic. Nothing wrong with the ovate pontic. I use it a lot. But what I prefer is to reconstruct the site, to reconstruct the ridge a lot. And then if I have so much tissue, if I have a lot of tissue, sometimes I don't need the ovate pontic. I can end up with a flat design or a step one. The step, because the gingiva is kept thicker. If I have a kind of step, I add composite only on the palatal side of the pontic. And when do I use one or the other? If I have the ideal vertical soft tissue reconstruction, a flat design is more than enough. But maybe I don't have the ideal situation, because dentistry is very unpredictable. What I mean is, you do 10 different CTGs. Every CTG has a different consistency. One is coming from the tuberosity, another is coming from the palate. A patient has a thick palate, another patient has a thin palate. Maybe you expect the perfect result, but in the end you don't have it. So if after the maturation of the soft tissues and its shrinkage, I'm losing too much tissue, I have to compensate that loss, adding composite on the palatal area, but not here. because if I add composite at the zenith point, the crown will appear longer. I don't want to add composite there. Finally, maybe I grafted the pontic side, but I still have a vertical defect, or I need to push the tissues more facially and proximally. Then I use ovate pontic. I use ovate pontics every day. But nowadays I have more solutions. And these are two examples. Look at the design of this prosthesis, is flat. But on the other situation, on the other clinical case, even when I grafted the site, I ended up adding more composite. This is the paper. And in this slide, I tried to summarize my idea that the more you graft, the less resin you need. The more you graft, the more you reconstruct the ridge with bones, soft tissue, whatever, both of them, one single, whatever, the more volume I have, the less composite I need. The less I graft, the more composite I need. Maybe the crown will appear longer, or I will have a concavity there. That situation is very stable. This situation is not so stable in the long run. Okay, this is the old way to treat our patients, prosthodontically. But now there is a new way. I've been practicing perioprosto. This is combining perio reconstruction, periodontal reconstruction of the ridge with the prosthodontic approach. On that side, we rehabilitate the patient only using prosthodontic tools. Okay? And how do we do this? How do we do this? Second paper was published to analyze how to do it. We reviewed the literature, and the easiest way to go is an interposition soft tissue graft. This is extremely predictable, as I said before. This is what I did in the previous case. I put a CTG between both flaps. And then the emergence profile, this emergence profile appears more natural because I reconstruct the tissues horizontally, but also a little bit vertically. And of course, there are many options. You know, many options. The more tissue you need, the more you modify the technique. And if you have a thick phenotype, maybe you don't need an autogenous graft. You don't need an autogenous graft because you can put the provisional holding both flaps apart. And this is an apical reposition flap. So my message is not you have to graft every single ridge, okay? My message is analyze the clinical case. Some cases you don't need a graft. In other cases you need a huge graft to reconstruct not only horizontally but also vertical. Maybe a very thick, large graft. In the same way, I used one in one of the cases. I don't know if you remember the huge graft. The whole palate was harvested. You know, there are cases where we don't need to do anything at all. There are cases where the graft has to be huge in order to rehabilitate the site. And how do I design the provision after putting there the graft? In the old times, I was told when I was a student, I was told to cut off the provisional, at least to cut off 2 millimeters, you know, to avoid any contact between the provisional and the graft. But I don't like to do that, because if I do that, I destroy the provisional and I need a second provisional. Instead of doing that, I started working with the inclined planes. The right length of the crown, but with a space in this posterior area for the swelling, inflammation of the graft. In that way, I kill two birds with a stone. I keep the right size of the crown, but I'm not exerting any pressure onto the graft. After the healing of the graft, I can add composite, I can design differently, I can switch, I can change the design of the provisional, but I don't need a second provisional. And I let it heal and mature. So these are the steps. I don't need to compromise the length of the crown. If I compromise the length of the crown in a patient with a gummy smile, the result is very unpleasant. I cannot send the patient home with a very short crown if the patient is 35 years old with a gummy smile. And there are many ladies with gummy smiles, beautiful teeth. I don't want to put there a very short tooth and then to switch that for a new provisional. Is not efficient. I'm wasting my time. I'm not giving the external result I want to deliver with my provisional. I need water. Are you speaking too much? Good? You follow me? I'm sure the translator is thanking me for these few seconds. Is Hi translating it right now? Yes? Hi. I don't know, where is Hi? Ah, okay. Okay, let's put an example. Let's put an example. And first of all, this was my purpose, my goal for many years. How to get here to get a nice transition area, but reducing treatment time and morbidity. Without so many appointments, without so much effort, in a different way. Reducing the morbidity for my patient, thinking about my patient. So immediacy is the answer. And I want to share with you this clinical case. Look at the man. It's not an ideal clinical case because we have a patient with bruxism, but the patient doesn't want to rehabilitate the full mouth. He wants to rehabilitate only the anterior area. Patient is coming with infection in the central incisor, no medical issues, no smoker. And we analyze the patient. We see that he has another fracture on the lateral incisor. In this lateral incisor, not only the central incisor, you can see the attrition. This patient would need veneers and to increase the vertical dimension, but she doesn't want to undergo that treatment. And this is the CBCT. This is the CBCT, and you can see the infection all around those roots. Lateral incisor on the right side of the mouth is gone, and there is only left a central incisor. I think you agree with me, it's not worth it to keep a single central incisor. So first thing first, I need an intraoral scanner. With the intraoral scanner and the CBCT, we match, we match both into the software, and we are able to plan the implant position virtually. We are going to put 2 implants to rehabilitate 4 crowns, not 4 implants, 2 implants. And we print a surgical guide at the office. This is the surgical guide. You see an example here, and my surgical guide with any sleeve. I'm not using sleeves anymore, because in that way I have one single gap between the shaft of the drill and the surgical template, not several gaps, because if I put there a sleeve, I have another gap between the sleeve and the surgical gap. And if I use spoons, another third gap. And the more gaps you have, the less precise the surgical template. If you have one single gap, the template is much more precise. So this is about precision. And this is the day of the surgery. Of course, I have to give antibiotics before because of the infection. I'm not going to place any implant there if the patient feels pain. Okay, I wait, I give antibiotics, the patient comes back, I arrange the appointment, and look at the defect there, 15 millimeters. So I selected, I avoided this side. I'm gonna place the implant on the lateral and the other center. And I'm gonna use several tricks here, several tricks. I'm gonna raise a tiny flap because I want to keep part of the roots there to maintain the periodontal ligament. If I'm able to maintain the periodontal ligament, the bone doesn't collapse. And I will preserve the papilla bone peaks. So I remove even on, in this central incisor, I was able to leave part of the distal root. I removed the rest of the root. I left on the rest, on the other central incisor, a C-shaped socket shield, and I put my implants. Put a couple of implants with surgical guide. You see here. You see here the pieces of the roots I left. You have to grind down the root properly to leave the root at the level of the bone crest. The same on the other incisor. So, if you pay attention, all the papilla bone peaks were preserved. Why? Because thanks to those socket shields, I kept the periodontal ligament in this papilla, the other one, and the third one, with the aim to maintain the escalloped shape of the transition area. Another advantage is that if I preserve the periodontal ligament, I don't need any soft tissue graft here. The drawback is I have to raise a tiny microflap to be sure that I'm grinding down the piece of root till the level of the bone crest, not above the bone crest, just a crestal. And from a crucial point of view, once again, you see my surgery, the design of the surgery. Be careful. You shouldn't leave a space between the implant head and the root. You need a space because if not, the root gets contaminated and maybe everything fails. So once again, you have to, I repeat, you have to thin a lot the root. I screwed onto the implant head the multi-unit abutments. I took the digital impression, and now my technician starts working at the same time I do the bone and soft tissue reconstruction. So I put the information into the software. And what is the design of the microregional? I need a concavity here to allow a space for the soft tissues. And at the bone sides, once again, you can see the inclined plane to allow a space for the soft tissues. Because now I have to reconstruct, you have to reconstruct those defects, the pontic sites. So I went to the tuberosity and I harvested bone and soft tissue from the tuberosity. Bone and soft tissue, the connective tissue and the epithelium, not only the connective tissue. I packed the bone on the facial side of the defect. You don't need to completely fill up the socket. you need to stabilize the position of the periosteum. This bone is soft, so once packed there, guarantees the regeneration of the area. Now I seal the sockets with the soft tissue I harvested from the tuberosity. The connective tissue with its epithelium. Not only the connective tissue, but the epithelium. And this is the final result. So everything was done simultaneously. Implant placement, extractions, but I kept part of the roots, and hard and soft tissue reconstruction. Now I need to load the implants, and I can, because primary stability is very high. You could see that the implants were very long. So patient went out of the office with the new provisional. This is before and this is after. So I don't compromise the quality of life of my patient putting their removable denture. But the main thing I'm doing is that I'm shaping, I'm guiding the healing of the soft tissues. And this is saving me a lot of time. Because after a few months, the transition area is not perfect, but almost. The only thing I have to do is to remove the provisional and to add a little bit of composite here at the pontic site to compress much more the ridge, to adapt the provisional much better to the ridge, because I've lost part of the volume. But with a single appointment, it's done. Everything is done. And now with the digital tools we have nowadays, we take a picture, we send the color information, and we took a triple impression. It takes nothing, 3 minutes. You register the provisional intraorally with its occlusion, extraorally, and then we send information not only about the occlusion and the shape, but also the pontic sites. You can see the composite I put there. And of course I registered the soft tissue condition, because now I changed that condition, adding more composite. So with that impression, we have every tiny piece of information sent to the laboratory. And now the technician does this. Puts that information, digital information, STL file inside Exocad. And this is the design of the zirconia framework. The technician reduces the volume and allows space for the layering of the ceramic. So we end up with this design. We obtain this design. This is the Type 3 zirconia framework, because this is a Abraxas, and Abraxas needs a strong framework. So in this patient, we are gonna layer ceramic, because Type 4 or Type 5 zirconia doesn't answer the demands of this patient. And this is the trick. With the zirconia framework, I'm compressing a little bit more, 0.5 millimeter more, the soft tissues, sealing perfectly the interface between the prosthesis and the gingiva, avoiding any air going throughout the gap. We need a model, because the technician is layering ceramic, and he delivers the prosthesis. And look at the design of the pontic. It's flat. Why? Because I reconstructed so much the pontic that I don't need to add tons of tissue, tons of composite there. Because the condition is favorable right now, thanks to the previous bone and soft tissue grafts. This is a flat design. This is the moment I put in the prosthesis, the final prosthesis there. But what is important is I went from baseline to this result in one single surgery, and another procedure to adapt much better the provisional to the ridge. This is flat. The design is not ovate, it's flat. CBCT for you to check out the condition of the bone. Everything is healing properly. Before and after. Before, after the surgery, and after placing the prosthesis, and we finalize with a night card, digital design, and this is before and after. And this is before and after. Still today, there are many people who remove those teeth. They wait 2 months. They put the implants after 2 months with a membrane and bone augmentation. They wait another 6 months. They expose the implant. They shape the soft tissues. Instead of 4 months, you spend 1.5 years treating a case. And they end up without papillae. Their result is much worse. So think about it. You have the option of delaying the implant placement. And this is for sure the worst thing you can do. I know that you were told so, that this is more predictable, and that is a myth. The more you delay, the less predictable the result. It's exactly the opposite you were told for many years. And this is, if you delay the implant placement and you open up the flap several times, it's almost impossible that you get that papillae height. You are complicating your practice, you are reducing profitability, your profit, you are reducing efficiency, increasing treatment time, morbidity, everything is much worse. And I say that because I've been sharing the stage with many guys, top speakers all around the globe for many years. And I've been there, listening to some guys saying that keep it simple, stupid, go step by step. Going step by step is the best thing you can do to kill yourself slowly. But if you won't suffer, I invite you to do it. Because some people want to struggle. So this is not fancy thing. I'm not doing this, and you can see the video, because I want to speed up the procedure. I'm doing this because biologically, from a biological point of view, it's much easier to guide the healing of the soft tissues, to guarantee a better result. Without the scars, you cannot see the scars because I didn't raise any flap. I'm not using vertical releasing incisions. I didn't compromise the papillae height. I'm able to deliver the treatment with a lower budget, and nowadays all around the globe, even in Switzerland or USA or Europe. Europe is becoming poorer and poorer every year, because new generation wants to travel, but they don't want to work. You can look at this in social media. You will travel, but without money. And this is not good. And this is in Europe, in Switzerland. You said there are many people who cannot afford a treatment like this. The more surgeries you perform, the more expensive the treatment is. So think about it. And competition in dentistry in Spain is really high. If your budget is very high, patients switch the dentist and you're losing the dentist. After 2 years, you are losing the family. After 5 years, you are losing all the mates of the patient and all the friends. So this is not a joke. It's not about a philosophy. It's about delivering the best possible treatment to the patient. It's not about aesthetics only. It's about biologically, and it's about competing in a new world, the dental field. And of course, from time to time, I do the same, but I don't get the ideal result. I don't get the ideal result. I grafted the side, but you can see that maybe I would need another graft. You can do another graft, or you can change the design of the pontic, but without modifying the position of the aesthetic area. Because if I add composite here, the crown will appear too long. And I don't want that. It will appear, sorry? It's time? Break time, yes, I finished with this. Thank you. And then, so I add the composite in the palatal side to push the gingiva facially and proximally without compromising the length of the tooth, without elongating the tooth. And this is the step design. Putting composite there guarantees me that I'm able to push the gingiva laterally and facially much more. And this is the final result. Okay? So this is the aesthetic, the step pontic design. And now I think we are going to stop for a break. Okay? It's time, thank you. And then we continue with the lecture. Okay?
Xin cảm ơn phần trình bày của